Very inspirational quote.
Well, it's always this is intended to remind people whether you're studying for your initial certification or your recertification that, this exercise is about knowing things, but being smart is more about being a clinician. So learn what you can, take the test, you'll be fine. It's not about how good a doctor you are. All right. So what they actually asked me to talk about was not A.A. Milne quotes, but preventive medicine. So I'm going to do a quick test of the polling to make sure I understand how it works. And the question is, who said an ounce of prevention is worth a pound of cure? Getting a mix. Benjamin Franklin currently leading. Do I stop the poll or do you guys stop the poll?
Steve will stop the poll.
Sweet. All right. So 43% of you got the correct answer. This quotation is from Benjamin Franklin. But as with many board questions, this is actually a multi-step question. The question was, what was old Ben talking about? Was it personal hygiene, pest control, house fires, diplomacy with the French, or flying kites in a thunderstorm? Wow, we have some ringers in the audience. 56% of you said house fires, and that is in fact correct. The remainder of you recognized that Ben Franklin was the ambassador to France, so kudos to you as well. So, brief sidebar. This is what he was talking about. The picture on the left is made up. They did not wear those hats back in Ben Franklin's day, so this was painted like a century later. But he was part of the first organized fire brigade in Philadelphia, which is why they hold him to be one of their own. And the innovation that he was talking about in the quotation is actually the thing on the right. That pot is a pot that people would use to warm their beds at night because in the 18th century they didn't have central heating. So you'd get some coals from the fireplace and bring them up to warm your bed. And his innovation was the perforated lid, and that what that did was it allowed you to carry the coals up and down the stairs with relative safety and not likely put your house on fire. The perforations allowed the coals to keep smoldering. All right, enough about that. Preventive medicine. So divided this up into four big categories: counseling, screening, immunizations, and then chemoprophylaxis. So actual medications to prevent things. Um, Despite some concerns about the current state of science in Washington, I still think that for boards and honestly for practical purposes, the work that has been done by the U.S. Preventive Services Task Force remains kind of the canonical source for this. And there will be occasions where there are discrepancies between their recommendations and other societies, and I'll try and pull those out. But in general, I'm going to be quoting USPSTF. They have five grades, of which A and B are basically equivalent. They are do it. A is a stronger recommendation, but for boards purposes, those are the same. D is don't do it. That one's easy to remember. C is an interesting one where they're basically saying don't do it for everybody, but there may be people who benefit. So that is sufficiently nuanced that I think it's a little bit less likely to be a testing point, although there may be occasional people for whom that would apply. And then I is insufficient evidence, and those are situations where USPSTF just has literally has said we have no opinion, we don't know. I wanted to do a quick note on gender. There are guidelines. UCSF are the ones that I'm most familiar with, but there are guidelines on how to do preventive care in transgender patients. It's a little bit of a talk in itself, but in case it comes up, I wanted to give you kind of a framework to think about it. So when I'm thinking about gender as it applies to preventive medicine, I think in a few different categories. So one is chromosomal. So for example, hemophilia A is a sex-linked thing, and that is I can't think of anything for which that category applies in the preventive space, but it's relevant for other diseases. Another category would be anatomic. So, for example, if you're thinking about cervical cancer or STI screening, If someone has a cervix, regardless of their gender, they need cervical cancer screening. Um, so that's pretty straightforward. Another one that's a little bit more complicated is hormonally mediated risks. So I think of this for breast cancer. Um, Trans women who are undergoing hormone therapy so that they have their own breasts probably have an increased risk of breast cancer compared to cis men. It may be less than cis women. It's a little gray, but those are people in whom you might want to think about screening for breast cancer. And then the inverse effect, if you have a trans woman who is doing anti-androgen therapy, that is going to lower their risk of prostate cancer. So it gets a little fuzzy in there, not seeing any test questions in that category because I think it's just too muddy. Then that's where I would recommend going to UCSF guidelines or other guidelines on this. Um, and then one more category that I think is important to think of is the social implications of gender. So if you think specifically about intimate partner violence, trans women are at higher risk of intimate partner violence than cis women. So that's a category where even though the recommendation doesn't specifically call out that group, I would really think about screening that group because we know they're at higher risk. And then there's like multifactorial stuff like AAA screening, where we truly don't understand the physiology behind why more men have AAAs than women. The recommendation is gendered, but how to mix that up if someone is transgender, I could not even begin to guess. Um, I mean, the bottom line is that they will probably likely either be an anatomic thing where it's straightforward or a gender irrelevant topic if you see any trans patients at all on your boards. All right, moving into the meat here. For counseling, 35-year-old woman transfers to you for primary care. She's married. She works full time as an engineer. She has two children under the age of 5. The nurse does your audit C at check in, and she scores 5 points on the audit C questionnaire because she has 2 to 3 glasses of wine on most nights. So the question is, what is the National Institute of Alcohol and I can't remember the other A's, sorry, definition of heavy drinking? Is it failure to fulfill occupational, school, or social obligations? B, continuing to drink despite negative health effects? C, more than 14 drinks a week or 4 on any one occasion for men, more than 7 drinks a week or 3 on any one occasion for women? D, drinking more than your doctor. While you're answering, I'll go on the sidebar. This is another interesting situation in which there's some physiology behind why it would be different for men and women, but I don't think it's really well understood. Nobody's choosing drinking more than your doctor. So much for the best distractor I wrote for the whole thing. Okay, 100% of you said more than 14 or 4 on any one occasion. Awesome. So the distinction that we're trying to make here is between at-risk drinking, which is a quantity-based thing, versus alcohol abuse or dependence, which were the other two things, social impacts, difficulty stopping. Abuse is the category that is the social and occupational problems, whereas dependence is frank withdrawal. The key thing to know from a preventive point of view is that people who are in that at-risk category but not yet in the abuse or dependence category, there is evidence showing that even a brief, like 2 or 3 minute office-based intervention can move the needle for them. So it's always worth asking, have they thought about cutting down? And they can say yes or no. Similar thing for drug screening and counseling, moderate benefit if there are resources available for treatment. And this one's a little bit trickier because it's not just a brief in-office intervention, but if you can identify people who you can refer for treatment, that is a valuable intervention. And kind of the same story for smoking. Worth pointing out, smoking cessation reduces all-cause mortality by up to 50%. The current USPSTF status on e-cigarettes is grade I, but there is the potential for that to get looked at again. This is 2021. As far as we can tell, the data on e-cigarettes is that they may decrease tobacco consumption, but they may increase nicotine consumption. So it's kind of specific to the individual how effective they are. Finally, obesity screening and counseling. You will notice this recommendation was issued in 2018. I absolutely expect GLP-1s to come up in the revised version of this. For now, they're basically saying if people have a BMI over 30, they're recommending intensive multi-component counseling. But I don't know what the timeline is for revising this, but I expect it will be revised now that we have more effective pharmacotherapies. Looking at diet and exercise specifically in non-obese adults, that's a C if they don't have cardiovascular risk factors. And it's a B if they do have cardiovascular risk factors. So this is kind of like assessing people's readiness to change, same as the other categories. Another counseling one that I thought was interesting because I hadn't seen it for a while is there is a skin cancer prevention recommendation, and it is for fair-skinned youth and young adults up to 24 years. And then over 24 years, it goes down to a C. And the reason for that is because so much there's a pile of evidence that those early years in life are really important for your subsequent risk of skin cancer. And one of the more compelling trials on that was done in Australia, where they have super high rates of skin cancer, as you might imagine. And what that showed is they randomized people to either broad spectrum sunscreen every day or usual care, applied the sunscreen for 5 years. So the intervention for the trial was 5 years, followed them for 15 years, and they found a 73% reduction in melanoma that was durable even for those 10 years after they weren't pushing the sunscreen anymore. I'm sure that there were some people who got into the habit and just kept doing it. But nonetheless, it is impressive. So this is like a wear your sunscreen, kids and young adults. Less important in our older population, but worth knowing in case it's a testing point. By contrast, screening for skin cancer, the complete skin exam, really the evidence on that is pretty poor. And it's important to recognize that there's a significant risk of overdiagnosis simply because the threshold for calling melanoma and pathology seems to be getting lower and lower. So there are more people with melanoma in situ that are getting treatment for things that might not actually metastasize in the future. So it's a little bit fraught. Don't expect it to be a testing point. Fall prevention. So the specific recommendation here, this was updated a couple of years ago, and they're recommending exercise interventions, specifically group classes in community dwelling adults who are over 65 and at high risk. Interestingly, the multifactorial interventions that a lot of us want to believe in, the send them to Falls Clinic and deprescribe and do all this stuff, grade C, because the evidence isn't as strong. And vitamin D supplementation to prevent falls is done. There were a couple of papers on that, but it hasn't panned out. Um, for STI prevention, this is different than screening, which we'll come to next. But in 2020, they recommended in sexually active adolescents and adults at increased risk, counseling people on how to prevent STIs has been shown to be beneficial. Okay, question break. Anything in the chat, Ananth?
Nope.
All right. I'll keep going then. So, question about screening. Seeing a 22-year-old college student, she's been sexually active since 17 with 4 lifetime sexual partners. She's had all childhood immunizations, including HPV. In addition to HIV, chlamydia, and gonorrhea, what should you screen her for? A, herpes simplex and syphilis. B, hep C and syphilis. D, hep C and herpes simplex. Or I'm sorry, C, hep C and herpes simplex. D, all three. A little bit of a mix here, but the correct answer is hep C and syphilis, and that is clearly winning the poll. So a few teaching points here. Number one, the recommendation to screen everyone over 18 for hepatitis C is a universal recommendation. Even if it doesn't make a huge amount of clinical sense in someone like this who's low risk, if it's in a test, you screen for hep C. Um, Syphilis recommendations have been extended to young adults. I'll come back to that in another slide. And herpes simplex is a do not screen. So we'll come back to both of those. First off, I mentioned HIV. That one's kind of easy. Everyone 15 to 65. Another frustrating thing here is that they don't comment specifically on the screening interval. And obviously, one-time screening for HIV for someone at high risk doesn't make any sense. So use your clinical judgment about how often to screen people. The question, if it comes, is probably going to be about do you, don't you? And the answer is yes, you do. For chlamydia and gonorrhea, the U.S. Preventive Services Task Force recommends screening sexually active women under 24. That is the population that is most likely to have bad outcomes from chlamydia infection. So what they're most worried about is PID and infertility. That's why it's focused on that group. Everyone else, you should be assessing risk and screening people with high risk. So this is just the population screening in this subgroup. USPSTF has an I recommendation in screening men because the evidence is fairly scant that screening men for chlamydia reduces those long-term consequences in women, and the consequences of having chlamydia for men are relatively small. So, making a distinction between what is the screening recommendation for everyone, which is for young women, versus what is the common sense thing to do in practice, which is screen everyone who you feel is at risk. Hepatitis C, I already mentioned the universal screening. This is another one where if people have ongoing high risk behaviors, you obviously want to keep testing. Herpes simplex, one of the things that I didn't realize until I was preparing this talk is herpes simplex tests are actually not that great. The ELISAs that they do for commercial tests are only about 80 to 85% specific. So if you start applying that on a population level, you're going to get a significant number of false positives. And the other thing is, so they're positive. What do you do? The one situation in which a positive herpes test is actionable is if you have one partner with herpes and one partner without, in which case the seropositive partner can take valacyclovir to try to prevent transmission. So in that unique scenario where you have a serodiscordant couple, then it makes sense to test. But if someone's just like, I'm worried I have herpes, I try to talk them out of testing because the test isn't that great and it's not really actionable information. Syphilis, on the other hand, is kind of growing across the United States, particularly has been on an upswing in Western Washington. And USPSTF has expanded their recommendation to include the high risk group includes all young adults, everyone serving in the military, any other concurrent STIs, men who have sex with men, sex workers, drug use, and incarceration. So that the young adults is broader than it used to be, and that was the point that I wanted to make here. Um, they also recommend screening for hepatitis B if people were not immunized and they come from a country where the prevalent or country or region where the prevalence is greater than 2%. So that is mostly going to be people from outside the United States because up until recently we've had population-based immunization against hepatitis B, or older folks. Uh, there is a conflict here because CDC in 2023, so that was during Biden, issued a recommendation to screen everyone who is 19 and older who'd never been screened before and immunize everyone up to the age of 59. I will say that one of my patients is a hepatologist, and when this recommendation came down and Hep B suddenly lit up on their dashboard, they were like, "What is this? This is the most stupid thing I've ever heard." Um, so I am here to teach you what the guidelines are, not necessarily how to practice. I think we can be more nuanced in practice in how we immunize for hepatitis B. I will say that the new two-dose Hep B series has changed my practice somewhat because it's so much easier to immunize people. I'm not thinking about it as much as I used to. But if you look at some of these folks who are in midlife, have no risk factors for acquiring hepatitis B, the argument for immunizing them is kind of meh. So I encourage you to think more than the guideline says, but the guideline is test and immunize if not immune. Where there's consensus between the two, everyone agrees that people at high risk should be screened and immunized. The only question is whether you do population screening like CDC says or high risk like USPSTF says. Generally speaking, with a conflict like this, you're probably not going to get a question on that level of nuance because they don't like that kind of ambiguous question. Another screening thing we're thinking about latent TB. This is a 2023 recommendation, and there the risk factors are unhoused or incarcerated people, people who come from an endemic region, or people who are immunosuppressed or going to be immunosuppressed. So people who are starting biologics, for example, you would also want to screen, or people who are candidates for transplant. Another question. 34-year-old man comes in for suture removal. His blood pressure today is 135 over 86. Last week when the sutures were placed, it was 138 over 88. He's healthy. He's not taking meds. He says, come on, doc, it's just high because I hate the doctor's office. Which of the following is true? A, this is elevated blood pressure and he should be monitored. B, he has white coat hypertension. Don't worry about it. C, he has stage 1 hypertension and we should treat him. D, he should get home readings. Overwhelming temptation to whistle the Jeopardy theme here, but I'm not going to subject you to that. We were so close, so close. Uh, we were, if you'd all gotten this right, I would have retired the question. The answer is D, and the take-home message is basically every guideline writing organization advocates for um, for doing at-home blood pressure measurements to confirm the diagnosis of hypertension. It's an A from USPSTF. I think it's a grade one from ACC/AHA. So if you get a question about whether or not people should get home blood pressures, the answer is yes. Interestingly, the diabetes recommendation, last updated in 2021, so subject to change, is a little bit softer than what we do in clinical practice. The USPSTF recommends only screening people who are at increased risk, so overweight or obese. I think most of us probably screen everybody. From my point of view, that's probably the better thing to do in practice. I kind of doubt this will be a test question because there's such a big gap between practice and the recommendation, but I wanted you to know that the recommendation is a little weird. And then AAA screening is this odd thing. I alluded to this earlier, where it's different for men and women and different for smokers and non-smokers. The key thing to remember is current or former male smokers between 65 and 75 should be screened for AAA. So age criterion, sex criterion, smoking criterion, and they have to meet all of them. The other categories I don't think you have to remember because they're not testable, although it is worth noting that the D recommendation is because this has been studied in female non-smokers and hasn't been shown to be beneficial. Okay, looking at osteoporosis screening, it's a B recommendation for women and I for men. And they recommend screening age 65 and up and younger women with who have multiple risk factors using some kind of tool. Meaning, typically we're using the FRAX without the DEXA because obviously this whole question is, do you get a DEXA scan? So FRAX with DEXA isn't helpful. FRAX without DEXA is helpful. But there is a conflict here because the Bone Health and Osteoporosis Foundation, which used to be the National Osteoporosis Foundation, recommends screening men. ACP recommends an individualized approach. I think if you get a question on osteoporosis screening, it's either going to be a 65 and up, otherwise asymptomatic woman without risk factors, or a woman who is younger than that but has multiple risk factors for osteoporosis, prior steroid use, things like that. I don't think they're going to ask you about screening men for osteoporosis because nobody agrees on what to do there. Screening for depression and anxiety, this is a B recommendation. This is why many of us have like a PHQ-2 built into our intake in our primary care clinics. They recommend screening everyone over age 12, rescreening women who are pregnant and postpartum because it's a very high risk population. They're test agnostic, so other tests are fine. PHQ-2 is pretty commonly used. Interestingly, in 2023, they also looked at screening for anxiety, and particularly in elderly patients, they were like, meh. And screening for suicidality was also found to be grade I, which is kind of helpful from the point of view of screening every single person for suicidal ideation probably is low yield. Obviously, if the patient is depressed, you have to ask the question. But this is about, do you just ask everybody? And the answer is they don't actually know, but not something that's going to be a testing point. Which patient should be screened for domestic violence, abuse, or neglect? Is it A, an 88-year-old man living with his son, B, a 38-year-old woman with her husband and daughter, C, a 26-year-old man with severe developmental delay living with his mother, D, all of the above? Okay, this is one where there's a gap between, I would say, both common sense and practice and the actual recommendation. None of you chose the actual correct answer per the recommendation, which would be B. Um, I think from a practical point of view, D is reasonable. So, U.S. Preventive Services Task Force looked at the data on this. They recommend screening women of reproductive age, regardless of any symptoms or signs, and there's a ton of different screening tools you can use. The reason why they don't recommend screening elderly and vulnerable adults is because there's insufficient evidence. To my mind, that is not enough reason to not do it in practice. So I think those of you who chose D, I'm right there with you. But if you're asking a question about what do the recommendations say, the right answer is going to be women of reproductive age. And personally, I told you as well. I think trans women too, regardless of reproduction. That's my own opinion. Don't take that to the test. But I wanted to highlight that because there's this discrepancy between what the recommendation said and what most of us would do in practice. Okay, how are we doing, Anant? Do we have any questions, any pauses?
No questions.
All right, I've knocked them into silence. Moving on to cancer screening. So cervical cancer screening, 67-year-old woman presents to established primary care. She's had one prior pap smear 20 years ago and was pretty sure it was normal. She's married and sexually active, but really would rather not have a pelvic exam. So what do you tell her in terms of what she needs for cervical cancer screening? A, she's over 65, so she's done. B, co-test now and stop if the results are normal. C, HPV only, then stop if they're low risk. D, HPV now and then repeat in 5 years, and then she's done. Interesting mix. Okay. So the correct answer is D, and a third of you chose that. Most of you really liked B. So let me go through the guidelines and explain to you why it's D and not B. These are both reasonable. C would also have been, in my opinion, if you're going to choose B, you could also have chosen C because co-testing doesn't add a lot of value. But let me walk you through this. Um, so cervical cancer screening in general, and then we'll focus in on that over 65 age group. In general, the older guidelines from USPSTF in 2020 and 2018 and the newer guidelines from the American College of Obstetrician and Gynecology recommend screening with cytology without HPV between the ages of 21 and 29, doing that a minimum of every 3 years. And the rationale for no HPV is because that's a population in which HPV is prevalent but often clears. So acting on high-risk HPV in that group would lead to a lot of overdiagnosis and needless colposcopies. From 30 to 65, then they say you can do just HPV alone or every 5 years or cytology alone every 3 years. They don't object to co-testing, but they don't feel it's necessary anymore. And then one thing that's new in the 2024 draft, which I still don't think is final, I should actually check that, is that self-collection of HPV is okay. So that's the first major guideline to endorse self-swabs. Um, Everyone agrees that there's no need to screen if they're under age 21. And then coming back to this specific patient, everyone agrees you do not need to screen over age 65 if you've had adequate prior screening. And the way that's defined is you need to have at least three cytologies or two HPV at the usual intervals, which for HPV would be 5 years, and your most recent one has to be at age 65. So because this person's last cytology was a long, long time ago, she needs two tests before she's off the hook. And that would be one now and one later. And because she really doesn't want a pelvic exam, I would lean towards self swab for HPV now, self swab for HPV 5 years from now, and that was D. Also, if you've had a hysterectomy at any age for benign disease, there's no cervix to screen, so you're good there. There is one conflict here that's worth pointing out, and that is with the American Cancer Society recommendations. American Cancer Society recommends screening starting at age 25 and just using HPV. So compared to ACOG that says let's do cytology for almost 10 years, 21 to 29, this results in a reduced number of pelvic exams, and that's ACS's goal. I don't think you're going to get tested on that. I do tell patients about it as an alternative, which I think is a valid alternative to doing cytology in that 21 to 30 age group. So, kind of looking at where they agree, everyone agrees 25 to 65, HPV every 5 years is fine. Well, I should say over 30 HPV every 5 years is fine. There's nuance in the 21 to 25. Everyone agrees you should not screen 21 to 25 with HPV. And then the difference is really focused on do we do cytology in that young age group or do we just start HPV a little bit earlier? The other thing that I think is a big question that I'm kind of stunned, honestly, still hasn't really been answered is what is the value of screening in people who have been immunized against HPV? Because it really seems like their risk for cervical cancer we know is really low. So, like, what is the appropriate balance between surveillance and even a self swab is a relatively invasive test, eh, if for something that people just don't need. So, I anticipate we're going to keep seeing more data and more guidelines on that. Switching over to breast cancer screening, 45-year-old woman expresses concern about her risk of breast cancer. Her mother died of it at 65. Three of her sisters are healthy. She does a monthly breast self exam. Her breast exam in clinic is normal, and she's asking for a mammogram. Which of the following statements of a breast cancer screening is true? A, women younger than 50 benefit from mammography. B, breast self exam reduces breast cancer mortality in clinical trials. C, mammography is more accurate in younger women. D, breast MRI is the preferred screening test for women younger than age 50. Okay, survey says most of you like A, which is MRI, or I'm sorry, which is mammograms are beneficial in women younger than age 50, and that is correct. The major points that I am trying to make here are that breast self-exam has actually never been shown to be beneficial in clinical trials. I don't discourage it, but I also don't like, tell my patients they're bad people if they don't do that. Mammography is less accurate in younger women, and MRI is not the preferred screening test because it also has a lot of false positive issues. So the recommendation from USPSTF, and there's actually decent consensus around this, is to start doing mammography at age 40, stop at age 74, or when they have other comorbidities that make it less beneficial for them. The one where there's obviously conflict is the biennial recommendation. USPSTF has historically been the only organization that recommends biennial rather than annual mammography, and they doubled down on that in 2024. I don't think the frequency is going to be a question again because there's such a big gap here between annual mammography, which is what most of us do, and biennial, which is what they actually recommend. But they could totally ask the question about screening people between 40 and 50 because that is a new recommendation that pretty much everyone agrees with. Let's move on to screening for BRCA. Patient's a healthy 34-year-old woman with a family history of breast cancer asking about genetic testing. Her mother had breast cancer at 55. Her grandmother had ovarian cancer at 62. So what do you recommend? Do you do the genetic testing, refer her for counseling, try and figure out her risk using like an online calculator or something, and then refer if she's high risk, or just do mammogram and breast MRI now? Have a mix. Okay, survey says most of you want to refer for genetic counseling. Some of you want to just do the testing yourself, and a few of you want to do the high risk, want to do the risk assessment. So the right answer is C, and this is a 2019 recommendation that did not get a lot of publicity, but they recommend assessing women's risk using a standardized tool. Breastcancergenescreen.org is one URL. It would be lovely if we had this built into our EHRs. Mine doesn't, but I feel like it should be in there. And then for people who are at high risk, you could consider genetic testing or counseling. They actually specifically recommend against just doing it. For counseling, the reason is just a workload issue, that there's so many people who could potentially be at risk that you would overwhelm the genetic counselors. And for genetic testing, it is really kind of an issue of, do you want to subject large volumes of people to genetic testing that has implications not only for them, but for their families and their offspring without appropriate counseling? Obviously, 23andMe did not get that memo, so I feel like people are coming in with their results now, so it's kind of less of a big deal. But if we're talking about what the recommendation is, it's assess risk first and then screen if high risk. Okay, this is the one I really want to retire, so I want everyone to get this right. 46-year-old man comes into your office for a routine physical examination, no family history of colon cancer. What is the best option for colon cancer screening? A, annual FIT. B, stool FIT DNA, FIT RNA every 3 years. C, colonoscopy every 10 years. D, patient's choice. E, doesn't need screening. Well, gonna stay
Oh,
in gonna stay in for another year. Okay, so about two-thirds of you choose colonoscopy, and one-third of you chose patient's choice. Patient's choice is the right answer. Um, Everyone, even AGA, agrees that anything that patients are willing to do for colorectal cancer screening is is the best option. So what we should be doing is trying to systematically get people through one of these doors. Any of them is fine because the reality is that still more than half of people are not getting screened at all. Um, the other testable point here is the lowering of the age threshold. So it's now an A recommendation for 50 to 75, but 45 to 49 were added as a B recommendation. So you could definitely get a question about screening people in that 45 to 50 age group as a newly extended risk. But you will not get a question about the question that I just gave you unless there's a patient's choice on there, because that is the acceptable answer. Whatever the patient is willing to do is the way to go. I didn't even ask you about like CT colography or, sigmoidoscopy or whatever, because we hardly ever do those, but literally anything that works. Um, Moving on to lung cancer screening. 72-year-old patient comes in for a routine physical. He has a 40-pack year smoking history, but is delighted to report that he quit smoking last year, otherwise healthy, wondering if he still needs his annual chest x-ray for lung cancer screening. So what do you say to him? Say, A, let's do a CT, but you should know that like 1 in 20 patients have a false positive study. B, let's do a CT, but you should know that 1 in 5 patients have a false positive study. C, sure, let's go with the chest x-ray because the CTs have so many false positives. Or D, you don't need to be screened. We have a mix of Okay, about half of you said 5% false positive, and about slightly less than half said 20% false positive. The correct answer is 20% of patients have a false positive lung cancer screening CT. And he is eligible by other criteria. So the eligibility criteria, a lot of numbers here, but 50 to 80, 20-pack year smoking history, and quit sometime within the last 15 years, or depending on if smoked, whatever. If they quit more than 15 years ago, they're not eligible. So it's a lot of numbers to remember. This guy clearly fits those criteria. I find the 50 to 80 to be easiest to remember. The other piece of this recommendation that we don't pay enough attention to is if they are so sick that they wouldn't survive lung cancer treatment, then you probably shouldn't be screening them. Now, lung cancer treatment is both more effective and less morbid than it used to be, so that's a little bit of a moving bar. But for people with like really advanced COPD who are not likely to survive aggressive interventions, maybe that's not the right person for lung cancer screening. One change in prostate cancer screening is it was a D and moved to a C. So this pendulum kind of keeps swinging back and forth, and now it's swung back to shared decision making. There is mortality benefit for prostate cancer screening, but it comes at the cost of an awful lot of morbidity. It's not a straightforward decision to make. If you get a question on this, it will likely be discussed with your patient, shared decision making, etc. It's not going to be a do it, don't do it kind of question. All right, we'll just keep going. Um,
and sorry, Dr. Knight, to interrupt. There was a
Yeah,
question
there
on
was a
the,
question.
yes.
I skipped the question slide. What's the question? Where am I?
So the question is from Jay, and it's about in relation to the cervical cancer screening and the ACS versus ACOG and USPSTF. Why were there increased colpos, I think, with the increased HPV testing?
They're increased colpos. Are we talking about in the ACS group, I assume?
I think so. And Jay, if you can
Yeah.
clear.
I might have been unclear in what I was saying. The concern is that because the follow-up for a positive HPV test is colposcopy, if you do a lot of HPV testing in a young group that often clears HPV, you end up doing colposcopies in people who didn't need them because they would have cleared their HPV. Does that make sense?
I think so. And Jay, let us know.
Okay. I think the one that started at 25, I think ACOG would argue that in theory, because they're saying don't start HPV screening until 30, there may be a higher risk in that 25 to 30 group. But really, we're talking about because it's every 5 years, you're talking about one HPV test. So I think the risk is kind of nominal. And a lot of this is more of a theoretical concern than a data-based concern because the studies are small enough that I'm not sure you're going to see. I'm seeing the zero point 0.9 to 1.1 difference. I'm not sure that you're going to see actual signal there, but it's kind of like yeah, it's theory, and there's a lot of in cervical cancer screening. I feel like we were talking about. Does this even make sense in people who've been immunized against HIV? So it feels like there's a lot of legacy data and legacy policies that are still kind of like waiting to be changed. I'm actually just going to skip this question and talk a little bit about pneumococcal vaccines. So the focus of the question that I just skipped is to recognize that there are only two pneumococcal vaccines that are one and done, and those are the PCV20 and PCV21 vaccines. 21 has a slightly extended spectrum, even it's actually better than it looks because what they did was they took out four irrelevant serotypes and added five more common serotypes, but it does miss one specific serotype that's common in unhoused patients. From a preventive medicine point of view, just get people their pneumonia shot, but if you're only going to give one, give 20 or 21. Also keep in mind that there are folks who need a pneumonia shot for reasons other than age. So people with chronic lung disease, people without spleens, CSF leaks, cochlear implants, immunosuppressed, et cetera. It's a fairly long list. And occasionally I'm like looking in my EHR and been like, why is it recommending a pneumonia shot? Oh, they have asthma. If people don't have a spleen, you should also add other encapsulated organisms. So that's meninge and Haemophilus influenza. And then other specific risk factors for immunizations, people who have a history of IV drug use, chronic liver disease, or high risk sexual activity should get both Hep A and B. And we already talked about B. One organization is saying immunize everybody. If you're not doing that, then definitely people with diabetes, end-stage renal disease, and HIV. Respiratory virus vaccines, who knows what's going to happen this fall? If for some reason you get a question on this, I would say the major focus is on that high potency flu vaccine over age 65 and the new recommendation for RSV vaccine in everyone over 75 and high risk over 60. But I honestly don't think you're going to get a question on that because it really feels like it's just constantly changing. Tetanus prevention, this one might be fair though. So 43-year-old person comes in after rummaging for auto parts in a junkyard, lacerated their left arm, really dirty wound, had to clean it out all the time. And their vaccination history was they were fully immunized in childhood and they got their boosters on schedule. Their most recent booster was 7 years ago. So for this person, do they need just a new tetanus shot? Do they need tetanus immune globulin? Do they need both? Or are they covered because their most recent booster was 7 years ago? Getting a nice spread here. So we have, yeah, okay. So 40% of you chose A, which is the correct answer in this case. They do need a shot. They do need a tetanus shot. They do not need tetanus immune globulin. And let me show you how this works to help you think through it. So the key teaching point, The only people who need tetanus immune globulin, if you look at the TIG column, are the people who did not get their primary immunization series. If you got your tetanus shots when you were a kid, you don't need TIG. So that makes that easier. Where this nuance comes in is this question of, is it a dirty wound or is it a clean wound? And if it's a clean wound, you're good for 10 years. If it's a dirty wound, you're good for 5. In this scenario, it was very clearly depicted as a dirty wound, so they would need a tetanus shot because it's been more than 5 years. This explains why when you walk into an emergency department with any kind of a cut, they just give you a tetanus shot because who wants to figure this stuff out? So in practice, if you want to give someone a tetanus shot because they have a lac, you go right ahead and do that. You're not going to hurt anybody. I think if there is a testing point here, it is the need for tetanus immune globulin, and that is only in people who have not had the primary series. Here's another immune globulin question. This is the healthcare worker one. 36-year-old physician stabs himself in the finger while recapping a needle. You should not do that. Source patient was surface antigen positive. They were immunized against Hep B 10 years ago during medical school. The best post-exposure management would be A, give them HBIG, B, give them a single dose of HBIG and then revaccinate them. C, test them to see if they're immune, and then if they're not immune, you give them HBIG and revaccinate them. Or D, they're good because they had their shots. Okay, we have mostly C, which is the right answer, a few A's and one D. Um, so the major teaching point here is there's a 7-day window that you have to give immune globulin. And you should not assume that someone is immune because they've had their shots, because a significant fraction of people do not actually develop immunity. So you have plenty of time for this individual to get, have their titer tested. If they are HB negative, then you can give them the immune globulin and reimmunize them. All right. Moving on. We're in the last section. So, breast cancer chemoprophylaxis. 42-year-old woman comes in with a family history. She has a family history of breast cancer, wants to minimize her risk, status post-hysterectomy for fibroids, and is otherwise healthy. Her estimated 5-year risk of breast cancer is 3.2%. What do you suggest? A, offer continue routine screening. B, test for BRCA1 and 2. C, offer her tamoxifen. D, offer her anastrozole. Okay. Survey says we have a C. Okay, tamoxifen barely leads the pack, and that is the correct answer. So nice work, y'all. A few continue routine screenings and one anastrozole. So I put this in because it is a not widely publicized recommendation. It was a B recommendation in 2019, and it was recommending assessing risk of breast cancer and offering chemoprophylaxis to women at high risk. Interestingly, in the recommendation, they don't specifically give a risk threshold, but if you look in some of the background stuff, most people say it's like 3% is where we ought to think about this. So this person was just over that threshold. And then in the choice between tamoxifen and raloxifene, she's a good candidate for tamoxifen because she's post-hysterectomy, so is not at high risk for the endometrial cancer complications. But if you put her on an AI, she would still basically have instant menopause. So we generally use aromatase inhibitors only in people who have already gone through menopause because of both the acute symptoms and the bone density implications. So tamoxifen would be the right answer for her. Here we go. This one's a softball. 72-year-old person with hypertension comes in for a preventive visit. They have an LDL of 163. They are only on lisinopril. There's obviously a lot to optimize here, but he wants to know, should he keep taking his daily aspirin? And is the answer yes, daily aspirin, B, compute risk and consider aspirin at high risk, or C, no aspirin? Okay. 75% of you said C, which is the correct answer. This was a USPSTF recommendation in 2022 to please stop giving aspirin to old people. So their cutoff is 60 and older, just don't do it. And then 40 to 60, you could consider doing it based on cardiovascular risk. In my own practice, I'm really trying to focus on the evidence that would suggest that people who need secondary prevention probably should be on a P2Y12 inhibitor, not aspirin, and people with AFib should be on apixaban and not aspirin. So I'm just, there's not a lot of reasons why I'm using aspirin anymore. Um, so definitely in this group of people who are, otherwise reasonably healthy, do not have known cardiovascular disease and are over 70, no aspirin, please. However, just as a heads up, we don't treat a lot of preeclampsia, obviously, in internal medicine, but it does have a role in prevention of preeclampsia. So if this crosses your radar and the patient that you have who's pregnant gets put on aspirin, that is a thing, and that's a legit thing. Probably not something we're doing ourselves. Other obvious stuff, prep for HIV, no surprise, 2019 USPSTF-A recommendation. Interestingly, the CDC in 2025 strongly recommended lenacapavir, which is the 6-month injectable prep, because it works really well. So that would be your go-to if they are fortunate enough to be able to afford and obtain that. Quick slide on other things that they have looked at and don't recommend. So they recommend against screening for COPD. They recommend against hormone replacement therapy for cardiovascular disease. No surprise there. And they recommend against vitamin E and beta carotene specifically for cancer prevention, but honestly, they couldn't find other uses for them either. And then they have a bunch of great eye recommendations, sleep apnea, atrial fib, both of which I think many of our watches are looking for now. They looked at other supplements, couldn't find much. Glaucoma, eating disorders, oral health, food insecurity, all things they've looked at, didn't have decisions. And then just a quick comment. It's like, what do we do now? Because USPSTF is on the rocks. CDC is not necessarily trustworthy. And I would say, look to your subspecialty societies. ACP has some good screening recommendations. The American Academy of Pediatrics is very engaged in immunizations. Look at WHO, look at Canadian and UK guidelines. But most importantly, I think, either advocate or engage with people who are advocating so that we can get our federal government back engaged in healthcare in the way they used to be. All right. That's the end.
Thank you so much, Dr. Knight.
My pleasure. Thanks for the invitation.
Of course. Hopefully, we'll see you next year.
I'll be here. Take care.